Hello, my name is Amir. I'm the hematology registrar. Welcome back in the channel Let's Bleep Hematology. Today we will talk about reinitiation of anticoagulation in intracranial bleed. Patients sometimes are admitted with intracranial bleed and they are using anticoagulation for an indication like mechanical heart valve, recent VTE, or atrial fibrillation or any other reason. So just like in case of gastrointestinal bleed, we discussed when to restart the anticoagulation. In in case of intracranial bleed, we also look at the risk of thrombosis and risk of bleeding. If the risk of thrombosis in the patient is high, then we restart anticoagulation earlier than those patients with the risk of thrombosis is less. For example, if a patient has mechanical heart valve, so this patient has a high risk of thrombosis. So we cannot leave this patient without anticoagulation, despite this patient is admitted with intracranial bleed. So in such case, we would wait for a week and or two. Most of the time, it is a week wait, and then we reintroduce prophylactic dose of low molecular weight heparin first for 3 to 4 days and see patient tolerability. If patient can tolerate low molecular weight heparin, in a prophylactic dose, then we make it a BD dose in the patient. If the patient can tolerate this BD dose of lumefantrine heparin prophylaxis doses for 3 to 4 days, then we increase the dose further if we want to introduce um, therapeutic doses. And then after 3 4 days, we go to therapeutic dose of the patient. For example, if the patient is requiring um, 120 milligram of enoxaparin as a treatment dose, I will give first 20 milligram dose for 3 or 4 days. If patient can tolerate, I will make it 40 milligram dose. If patient can tolerate for 3 to 4 days, I will make it 40 milligram BD for 3 to 4 days. And then if the patient can tolerate this as well, then after 3 to 4 days I will make it 60 milligram BD for the patient. So this is a therapeutic split dose of the low molecular weight heparin for the patient, and then I can convert back to bridge it back to warfarin. So this is a slow grading of the low molecular weight heparin towards therapeutic doses, and then going back to warfarin in a patient with mechanical heart valve. Because they are high risk of thrombosis, we cannot keep them without anticoagulation for a long time. But remember, approach is different in every trust and different by every hemostasis consultant in the same hospital as well. So always follow your trust guideline and listen to your hemostasis consultant. Then, if there is a patient which has a recent VTE, or if the Chadwa score in the patient is high, then we would follow the same approach. Um, Wait for a week without anticoagulation for a week after endocrinal bleed. If on repeat scan hematoma is stable, not expanding, then I will reintroduce prophylactic or small dose of low molecular weight heparin first, then increase the doses of low molecular weight heparin after every 3 to 4 days to see patient tolerability. And after every 3 to 4 days, I will increase the dose of low molecular weight heparin and reach to therapeutic doses. And after that, I can convert back to the Duoco or warfarin, whatever the patient was using. But if the patient has low risk of bleeding, low risk of thrombosis, like a patient with atrial fibrillation, but the Chadwa score is low, or if the patient was on long-term anticoagulation and the last BTE was many years ago, then I can wait for 3 weeks, and then after 3 weeks, if the hematoma is stable, I can introduce prophylactic doses of low molecular weight heparin, and then increase the dose slowly if required, or if the patient can tolerate prophylactic doses, then I can go to patient normal anticoagulation after 3 to 4 days. For example, if a patient was on apixaban, for example, prophylactic dose for atrial fibrillation, and the patient has a traumatic intracranial bleed, I can restart luminary with heparin after 3 weeks and see whether the patient can tolerate it um, after uh, after 3 days or not. If patient can tolerate prophylactic luminary heparin doses, I can restart prophylactic apixaban doses in this patient again. Similarly, if the patient was using warfarin for AF, I can introduce lumekrivit heparin after 3 weeks, but with prophylactic doses. If the patient can tolerate that, after 3 to 4 days, I can do the bridging in the patient. So it depends on the risk of thrombosis in the patient. If the thrombotic risk is high, re-anticoagulation is early. If the risk of thrombosis is low, reintroduction of anticoagulation is late. In cases of high risk of thrombosis, wait for a week and then introduce graded up doses of lomoglurate heparin. In low risk of thrombosis, wait for 3 weeks and then on fourth week uh, introduce the lomoglurate heparin. In both cases, make sure hematoma is maturing and there is no expansion. And the important thing is that because there is no specific guidelines for this topic, listen to your hemostasis consultant and follow your hospital or trust guidelines. Thank you very much.